Good afternoon, everyone, and welcome to this session. Before we get started, I'd like to acknowledge the traditional owners of Naarm, the peoples of the Kulin Nations on whose land we're gathered today. I recognise their continuing connection to land and sea and acknowledge that sovereignty was never ceded and that this was and always will be Aboriginal land. I pay my respects to elders past and present and extend that respect to the elders of all First Nations communities that are joining us today. I commit to being open and humble, to practice deep listening and to walk together with respect with Australian, Aboriginal and Torres Strait Islander peoples, communities and organisations in a shared journey to better health. And I stand for a future of shared mutual respect and partnership with First Nations peoples of this country and other countries in the world. So thanks so much for joining us today for this session. My name's Sarah McGuinness. I'm an infectious diseases physician, educator and researcher based at Monash University and Alfred Health, and I'll be your moderator for today's session. In recent years, we've witnessed disruptions caused by infectious diseases, with the pandemic straining already fragile healthcare systems and workforces. And we've seen some concerning trends in the resurgence of vaccine-preventable diseases, climate-driven expansion of mosquito vectors, antimicrobial resistance threatening prevention and treatment of an increasing range of infections. And our response efforts have been complicated by mis- and disinformation. But despite these challenges, there are some opportunities for innovation and collaboration. And today we'll be exploring infectious threats in our region through the lens of 3 innovative programs that are engaging with communities to tackle high-burden infectious diseases affecting our region, like dengue, tuberculosis, and vaccine-preventable diseases. Today we'll be getting insights from our expert panel on successes and challenges, lessons learned, and how we can leverage their learnings and approaches to address these and future health challenges. And I think this session aligns really nicely with the challenges put to us by Director Pukala, the WHO Regional Director of the Western Pacific, earlier today, where we were asked to consider how well we frame our problems and ground our solutions in the voices of the people, adapt solutions to fit local communities and cultures, and capture local innovations. So the session today will be in 3 parts. First, we'll have a brief showcase of each program, and then a funder government perspective, and that'll be followed by a facilitated panel discussion, and finally we'll get you, the audience, involved in a Q&A. So in the interest of time, I'll keep the introductions of our fabulous speakers brief, but you can read their full bios on the app and the website. So to start, let's begin with our first showcase on the Western Province TB Partnership in PNG. So this 10-year program is partnering with the Provincial Health Authority to combat tuberculosis, engaging with the community and strengthening the healthcare system in a setting that's grappling with one of the highest rates of resistant TB seen globally. Joining us to introduce this program today is Associate Professor Suman Majumdar from the Burnett Institute. Thank you, Suman.
Thanks, Sarah and the organisers. That's a long walk up to the stage, so I almost tripped over there, but thank you. So to introduce this program, and I'm speaking here today with Dr. Nico Utai, who's the CEO of the Provincial Health Authority, where our work is based, and we work in partnership, as Sarah mentioned, for over 10 years. I'm also speaking on behalf of a huge team of colleagues over many of years. I work at the Burnett Institute, that's been the main partner supporting the local government and community. A couple of colleagues are in the room, Sarah Corver and Steve Graham, but there's many others. Firstly, just to frame tuberculosis, for those of you that are not familiar, it's one of the Sustainable Development Goal number 3 is to end TB by 2030. There is the WHO End TB strategy, which that graphic outlines, requires significant pushes in innovation and delivering standards of care globally in what is perhaps one of the pathogens with the most inequities as we see. High-income countries like Australia have eliminated TB in the post-World War period through mass screening and community-based interventions. That hasn't been the case for the majority world, and we still see TB cause significant socioeconomic catastrophic costs and really stressing health systems that are already quite vulnerable. There was a high-level meeting in 2023, along with the pandemics and universal health coverage on TB, that reaffirmed the massive needs, but also the urgency of the issues to accelerate progress against TB. The context which we're going to talk about today is in Papua New Guinea, and the coloured map The satellite map shows you the southern part of Western Province, that's South Fly District, that's cut through by the massive Fly River here. This is Indonesia on this side, and the Australian border runs right against the coastline of PNG here. The provincial capital is this dot here, Daru Island. Oh, I'm sorry, you can't see my cursor, I'm just pointing to myself. But you can, hopefully I've talked you through that. The blue map is TB case notifications across the country, just showing that those southern regions, and particularly Western Province, are high transmission settings for TB generally, but also for drug-resistant TB. And the images in this presentation have all been used with consent of the people that have been photographed, and the catastrophic costs are really borne when you work in a setting such as this. The community in Daru in particular is a settlement-driven community with displacement caused by the Oktedi mining disaster many years ago. So there's a geopolitical element here and an environmental health element to the upstream determinants of the TB problem. People have migrated into a settlement area. The poverty here experienced is perhaps some of the worst in the whole region. CSIRO have done some studies and looked at household poverty indices, which have been really on par with some of the lowest in the world. Add to that the difficulty of delivering healthcare in a place that is very rugged, very remote, with boat and very limited road access required to go between villages and deliver healthcare, let alone general services to the province and to the district. In PNG, this chart is just illustrating, these are the main hospital in Port Moresby, and over a 5-year period looking at the admissions in the coloured graphs and in the blue, the deaths, and TB ranks very high above all other conditions in terms of hospital admission and death. So we do see a very particular high level of tuberculosis in PNG compared to many other Pacific Island countries and also in the region. That's compounded by drug resistance, and drug resistance has been a particular feature in hotspots, such that in 2014, the National Department of Health convened an emergency response task force with partners, with WHO, and included international partners such as MSF, World Vision, ourselves at the Burnett, and many others, eventually the World Bank as well. This raised the issue to the highest level of political priority, to the Prime Minister at the time, and to the executive government, requesting political commitment and funding and resource mobilisation. Dr. Wutai will talk to some of this during the panel, but what this emergency response did, now people might say TB is not really an emergency, it's a public health chronic issue, but the commitment that was required and the urgency to solve a complex problem in this setting which has broken systems was really important. The gentleman there is the late Dr. Pyson Dakalala, who was the Deputy Secretary, who was really an inspirational and amazing leader at the time, who convened this and has been a champion for strengthening the health system in PNG and particularly TB. He recounts stories where his family had been affected when he was growing up. I'll now quickly outline our work specifically in the South Fly and in Daru. This is Alan and Ethel, who are counsellors in the program. And the program that has been funded by the Australian Government through the PNG Australia Partnership is RID-TB, and it's a partnership model of technical assistance and implementation support, essentially working together on the ground with the government and the community to troubleshoot and to achieve the two key outcomes of responding to TB, improving outcomes there, and also strengthening systems where possible. Some of the work done in the early few years was really clinical and hospital-based, setting up a model of care. But importantly, that model of care moved from the facility to the community and set up a model of counselling, including nutritional and food support. A key part of the program was working in governance and other health systems areas, where we worked through supply systems, data and information systems, to monitor, to troubleshoot, and to work to the national level. This is the High Commissioner to PNG from Australia at the time with the provincial leadership, and the photo of the gentleman in the corner is Dr. Stenard Hiasiri, who was the provincial TB leader who we worked very closely with for a number of years. Just to illustrate the remoteness of the setting, this is one of the community treatment sites and a peer counselling session that's occurring. Despite being a small island, there is pockets of overpopulation and pockets of remoteness as well. And then when you go into the mainland, there's even, it is a very low resource and remote setting. A key feature of the partnership, which the partner World Vision has been really catalysing, is community empowerment with support from our team and the provincial government leading the overall response, has been to put the voice of the affected community at the centre of the response. Can't understate how important that has been and how critical it's been to inform the needs and even specific details such as the model of care that is patient-centred or person-centred and family-centred. A final intervention has been training and capacity building, and this is one example where research training, through operational research training using the WHO TDR model, was being delivered in a very challenging setting and replicated a second time. Professor Steve Graham has played a leading role in this course, and it's led to this first output, which was perhaps the first publication of TB studies, 14 first author Papua New Guineans who were then being trained in research methods, describing the experiences in their province and also particularly in this program here in South Fly. Very quickly, whilst I'm speaking to PNG, I want to recognise that the Australian government in particular as a partner has supported tuberculosis in the region, primarily through a consortium between Menzies and the Burnett, working with Indonesian and PNG partners and also in Timor-Leste over a number of years. This has been a strong partnership that's led to implementation in very challenging settings such as Mimika in West Papua, the programs in Daru, other parts of PNG and Yogyakarta in Indonesia. The chart at the top shows the case notification rates in that South Fly and Daru. You can see the emergency response led to a reduction in case notifications. There was some active case finding that led to an increase. And when the pandemic hit, like most settings, people did not access health services, so TB notifications dropped off. Transmission may have increased, and then as case finding has started up again in the last 12 months, we've seen an increase in overall cases. This is Dr. Wutai championing the COVID vaccination, and what I wanted to illustrate here in this pandemic setting was, as the health system was crippled, not to use that word lightly, the health system strengthening developed resilience in the local health system such that the health workforce could pivot and deliver COVID vaccination and other programs, as did the community engagement teams, to deliver one of the highest rates of vaccination in PNG, noting that there's still a long way to go in vaccine uptake in PNG. Now, the other message from this is that transmission still remains very high. The case notification rate of TB in this setting is around 2.6%, and for drug-resistant TB it's around 0.5%. So it's extremely, extremely high for a pathogen and for TB, and therefore additional interventions beyond standard of passive case finding and detection is required. So with the province and the community, a program that proposes and has commenced to systematically screen with engagement, detect, treat and prevent TB has commenced. And this is a large initiative that's been stalled by the pandemic, and we're in the early implementation period of this, working together with a large group of partners under the leadership of the Provincial Health Authority. I won't read through all the slides there, but the aims of this are to reduce the incidence measured by case notification of tuberculosis in Daru. There's a similar project in Kiribati, led by the University of Sydney, again working with the Ministry of Health there, and both projects have very similar aims to detect, treat and prevent. In this setting means administer TB preventative therapy to people that have evidence of TB infection, which is a skin test. This is a very complex and difficult intervention where we've worked with the community to work at the household level rather than facility or fixed point screening. We're using new tools such as artificial assisted X-ray in the community that's mobile. Nutritional support and person-centred care is fundamental for delivering this and for high uptake. These are some pictures of the screening sites, some of the tools that have been used for engagement and education. To date, around 3,500 people have been screened. There's been a number of people, around 60 or so, detected with active TB and around 300 put on preventive treatment. Central to this has been a community advisory group who have been formed as a really key body in the program, representing different sectors of the community, businesses, church leaders, and other key populations who inform this particular program in terms of how to screen, how to engage, and are a key part of leadership in the SWEEP TB program. Finally, I'd like to just close by acknowledging the funding support provided by the Australian Government, both through the High Commission and through the Centre for Health Security over the years through successive projects. And we will look forward to discussing the progress and challenges of this work in the panel discussion to come. Thanks very much.
So thanks so much, Suman, for that brief overview. Next, I'd like to call Katie Anders from the World Mosquito Program up to the stage, who will be talking about their program using novel Wolbachia method to tackle dengue and other arboviral diseases across the region, including in Indonesia. Thank you, Katie.
Yeah, there we go. Okay. Good afternoon, everybody. Many thanks, Sarah. Many thanks to the organisers for the opportunity to participate in this session today. It's great to hear about the TB program that Suman's just presented to us. As Sarah mentioned, I work for the World Mosquito Program, or WMP. We're a not-for-profit organisation wholly owned by Monash University. We were a research program in the Faculty of Science at Monash University that a couple of years ago became an entity, a not-for-profit entity, wholly owned by Monash. And we work with our global partners to scale up the implementation of a technology that was developed over 2 decades at Monash and prior to that at the University of Queensland, that involves the release of mosquitoes carrying a common insect bacteria called Wolbachia to protect communities against dengue and other mosquito-borne viral diseases, including chikungunya and Zika, that are transmitted by the same species of mosquitoes. So I'll come back to how Wolbachia works in a moment, but just to set the scene, if I can progress the slides. Nope. Maybe on here. Is that not working? How do I do this? Whoop. Oh, I point it there, not up there. That makes sense. Yep, thank you. There we go. Nope. Sorry. Can anyone in the technical team advise? There we go. Thanks. So the need for new and effective tools to control dengue and other arboviral diseases is an urgent one. The World Health Organization ranked dengue among the top 10 global health priorities in 2019. And half of the world's population, around 4 billion people, live in areas at risk of dengue. Around 400 million infections are estimated to occur every year, of which about 100 million are symptomatic cases. And this has been estimated to cost the global economy around $12 billion a year. The size and frequency of dengue epidemics, dengue outbreaks, and the number of countries that are affected has really increased dramatically over the past couple of decades, as shown in this graph here, which shows the number of dengue cases notified globally each year. A record 6 million cases were reported globally in 2019 and again in 2023. And then this year there's been a surge in dengue transmission both in Asia and in Latin America that's seen the number of reported cases exceed 5 million already in the first few months of the year. The dengue mosquito also transmits Zika, chikungunya and yellow fever. And these viruses have emerged with epidemic spread in the last decade as well. Climate change and urbanisation are really the two key drivers of this resurgence and emergence. And these two factors have been projected to put an additional 1.5 billion people at risk of dengue by 2050 due to an expansion in the areas that are suitable for dengue transmission under a warming climate, together with population growth in those large tropical cities. Conventional approaches to dengue control focused on insecticide fogging, as shown in the pictures here, and environmental control to reduce mosquito breeding sites are necessary but haven't been sufficient to meet this formidable challenge. So there's really a need to integrate new evidence-based tools into dengue control programs, and that includes vaccines as well as Wolbachia that our program's been working on. And so I'm going to let this short video that hopefully plays tell you how Wolbachia works.
The mosquito known as Aedes aegypti originated in Africa. Over the last 400 years, it has spread throughout all tropical regions of the world, transmitting viruses like dengue, Zika, chikungunya, and yellow fever. Today, this mosquito puts more than half the world's population at risk of dengue alone. But we made a breakthrough that changed everything. We found a way to prevent Aedes aegypti from transmitting dengue and other mosquito-borne diseases. Our method uses safe and naturally occurring bacteria called Wolbachia that live inside insect cells and are passed from one generation to the next through the insect eggs. Here's how it works. Wolbachia are found naturally in an estimated 50% of all the different species of insects. Insects that include fruit flies, moths, dragonflies, and butterflies. The secret to the success of Wolbachia is how it manipulates the reproduction of the insects it lives in to give itself an advantage. It works like this. If a male insect has Wolbachia and mates with a female that doesn't, then the eggs she lays won't hatch. If the female has Wolbachia and the male doesn't, she would lay her normal number of eggs. They would all hatch and all offspring will carry Wolbachia. When two insects that both carry Wolbachia mate, the eggs will hatch and all offspring will carry Wolbachia. Over a few generations, the number of individuals carrying Wolbachia increases rapidly until nearly all the insects within a population have the bacteria. We wanted to see if we could use Wolbachia as a way to stop dengue transmission. To do this, we would first have to move Wolbachia into the mosquito so that it would grow and be passed between generations. Using microscopic needles, we took Wolbachia from the fruit fly and injected it directly into young Aedes aegypti eggs. It took us thousands and thousands of attempts, but finally, we were successful. And once the mosquitoes carried Wolbachia, they naturally passed it on to their offspring without the need for further injections of Wolbachia. We then took the mosquitoes that contained Wolbachia and infected them with dengue and found something really exciting. The virus didn't grow well in the mosquito, and if it can't grow, it can't be transmitted between people. Our next step was to test the approach in communities where dengue had been a problem for years. Wolbachia mosquitoes were released once a week for 10 to 20 weeks, and within a few months, close to 100% of the mosquitoes had Wolbachia. Years later, they still do. The results are clear. Dengue cases have dramatically decreased in communities where Wolbachia mosquitoes were released. It is our hope that with continued success, the Wolbachia control method will protect the health of the nearly 4 billion people globally who live with the risk of dengue and other mosquito-borne diseases every day.
Okay. So since the first field releases of Wolbachia mosquitoes, which were done in northern Queensland in 2011, WMP's worked with governments and communities in 14 countries to deploy this intervention in more than 30 cities so far, reaching around 11.5 million people by the end of this year. And one of the earliest partners was the University of Gadjah Mada in Yogyakarta, Indonesia, where we're still collaborating today, and my co-panellist Chitra Indriani is here representing that program site. Engagement with and partnership with governments and communities has really been central to the way WMP's operated right from the start. As you might have picked up, this is sort of a counterintuitive intervention, releasing mosquitoes to prevent mosquito-borne diseases. So engaging with a broad range of stakeholders to ensure that this Wolbachia method is understood and accepted and supported by the local community before a single mosquito is released in any project site has been the model for community and stakeholder engagement all the way through. And not just to make sure the communities are aware and accepting, but to actively involve them in hosting the mosquito release containers and the traps for field monitoring of Wolbachia. In terms of effectiveness and impact, in collaboration with the University of Gajah Mada, we've shown in a cluster randomised controlled trial that finished a few years ago that Wolbachia releases are highly effective in reducing dengue incidents. In this cluster randomised trial, there was a 77% reduction in dengue incidents in the Wolbachia treated neighbourhoods, 86% reduction in hospitalised dengue cases. And then the real world evidence that's been accumulating since then in the cities where not doing a trial, but phased citywide rollout of Wolbachia has been done as indicated by that sort of stepped blue shading on these graphs. We've seen that there's been a sustained interruption of those regular seasonal dengue epidemics shown by the line, which is the monthly notified dengue incidents per capita in each of these sites. In Yogyakarta, regular annual epidemics every year, and in that's on the top, Yogyakarta, and on the bottom, a city nearby to Rio de Janeiro in Brazil called Niterói, 500,000 people, where these very large dengue outbreaks historically have been interrupted since the citywide deployment of Wolbachia. In Indonesia and also in Brazil, the central governments have committed funding now to scale up Wolbachia deployments, led by municipalities, funded by the federal government, to 5 cities in Indonesia and to so far 5 and another 6 about to start in Brazil. So just to finish up by saying, as a program, World Mosquito Program sort of at a pivotal point now, having transitioned from that sort of lab to field translational research program to now working to partner with governments and funders and others to accelerate global uptake of the technology. And I've highlighted here a few of the key priorities that we see in that transition to scale. From a technical sort of point of view, we need to industrialise the way mosquitoes are produced and distributed to be able to make enough mosquitoes to deploy over very large cities of 5 to 10 million people and get the mosquitoes to those cities in the numbers that are needed. From a regulatory and sort of policy perspective, Wolbachia infected mosquitoes are a novel product class with a novel mode of action. So the pathway for regulating this technology and product registration is not a well-trodden path. It's being navigated as we go, and it's probably a bit different in different countries. Cost and cost effectiveness of the intervention are clearly key. And transitioning from research program to sort of scaled implementation, financing mechanisms are needed to ensure affordability and equity of access, because vector control programs for dengue have very low budgets. Not a lot is currently spent on other interventions for dengue, so even redirecting those budgets, there's not a lot to work with. Large-scale delivery needs to be integrated into existing dengue control programs, moving away from WMP-led project teams doing end-to-end implementation to where this is integrated into existing public health workforce, and we're supplying the mosquitoes and the technical support for that. And then with delivery at larger scale and by a different range of implementers, there needs to be clearly ongoing evaluation of those public health outcomes to see reproducibility of what we've seen so far in terms of effectiveness, and to understand how durable that impact is going forward. So this slide shows our many partners and funders that we're very grateful for their support. together with some of our key NGO partners, Save the Children and MSF, who are leading the implementations in some countries, and University of Gajah Mada, who's the key partner in Indonesia. Thank you.
Thanks so much, Katie, for presenting on that amazing work. So next, I have the pleasure of introducing Dr. Jess Kaufman to the stage to talk about the Vaccine Champions Program, which trains vaccine advocates and supports vaccine confidence and capacity building across the region, including in the Philippines. So thanks, Jess.
Thanks so much for having me and for the opportunity to speak among so many other great programs. It's really great to be here. I'm speaking today on behalf of the Vaccine Champions Program, and my colleague Margie Danchin will be joining the panel to speak a little bit more about it, as well as our colleague Professor June Belisario from the Philippines. So I really want to reflect a little bit on some of the things I've been hearing just in all of the talks today. Some of the most important messages, I think, have been around the importance of trust and trusted messengers and trusted relationships when we're promoting health programs, particularly around vaccination. Also the value, obviously, of community engagement, of listening to community members, of bringing communities on board when you're putting programs into place, and of understanding what the priorities are in a given setting, in a given country, before you sort of implement a new program. And also I listened to some talks just after lunch about the really devastating impacts of health workforce shortages, particularly around our region, and how stretched and overburdened and burned out our health workforces have been, particularly through the COVID pandemic. And really, those are the principles and the factors, I guess, that underpin the whole concept of the Vaccine Champions Program. So this really came about initially in Australia during the COVID pandemic, when we were working together with a number of our different partners, social scientists and vaccinologists, looking to support the Victorian government to promote COVID vaccine uptake. And like many places around the world, we learned very quickly that one of the most effective strategies was actually getting people from all around the community to share their vaccination experiences and to become advocates for the vaccine, with that idea that, our health workforce can only reach so many people. Our government messaging can only reach so many people. But if we have a really diverse group of people who are all sharing messages, all promoting vaccination, all explaining how vaccination aligns with their values and their shared values within their communities, it ends up being much more like this ripple, and it reaches so many more people with so many different messages that are all in support of vaccination. So that's really the principle of the Vaccine Champions Program, which we then have gone on to adapt and co-design and implement in a number of different countries with support from the Australian government through the Australian Regional Immunisation Alliance, and with a whole range of great partners. So the first two places that we have worked with the Vaccine Champions Program have been sort of smaller scale settings, so in Fiji and in Tonga. And the way this works in the smaller scale settings is, as in other settings, we start with a co-design workshop where we actually meet with a whole range of government stakeholders, NGOs, people from the community, health workforce representatives, and we bring them all together to understand what the barriers to vaccination are, what the key vaccines are that is the current priority. So in Fiji, it was really about the COVID vaccine in 2022, whereas in Tonga, it was about the HPV vaccine, which they're just launching in the last year. So, understanding what they wanted to focus on and who would make sort of an ideal vaccine champion in that setting, and what they needed to learn and understand in order to be effective champions. Then we brought those champions together and we ran multi-day training workshops. And the training really is beyond just explaining, you should go out and tell people that you were vaccinated. Sometimes we think of that as a vaccine champion. And in COVID, you might have seen a sports star on TV saying, I got my vaccine, you should get it too, which is great. And I think that's really important. But our program went beyond that. We wanted people to understand key information about vaccines. We wanted them to have practiced having difficult conversations about vaccination so they felt confident broaching it with people who might have been vaccine hesitant or had tricky questions. And we wanted them to have some skills so that they would be able to address or at least stop the spread of misinformation about vaccination. So it was a little bit more complex than just standing up to be counted. In Fiji, this is the smaller scale nature of these programs. In Fiji, we trained 35 champions, and in Tonga, we trained 27. But those champions went on into their communities to reach over 1,500 people in the community in each setting, and they ran information sessions or discussion sessions within their community. And so that could have been within a church setting, or we had Fiji rugby players or coaches involved, and we had educators. We had people from lots of different backgrounds talking to their communities about vaccination. And throughout that whole program, of course, we were doing monitoring and evaluation, trying to understand the impacts of the program, not only on the champions themselves, but also in the community. A larger scale version of the program was undertaken in Vietnam, and we are now about to start another version in Indonesia. So these are much, much bigger countries than Fiji and Tonga. They still start with the same initial co-design workshops. So we brought together, again, working with our excellent partners in Vietnam, the Woolcock Institute, we brought together UNICEF, WHO, Ministry of Health, NIHE, all the different organizations that were involved in vaccine delivery in Vietnam. We translated everything into Vietnamese. We had great partners who helped us run through all of the translations and the materials. And in Vietnam, it was a focus on COVID and routine childhood immunization. Then we do sort of a stepped approach, and this is the idea of reaching more people through a train-the-trainer model. So we trained 6 master trainers who had expertise in vaccination and communication, and then they went on to run training sessions with 143 provincial trainers. So these were people from different areas who had some health background or some health communication background. And then those provincial trainers went off again to the next level down to train vaccine champions from local commune areas, who then again went out into their local commune and had conversations about vaccines with the people in their area. And now we also know that those champions that have been trained are being upskilled in other health promotion concepts like nutrition and maternal child health, so which is an example of that sort of integration and sustainability of this model, which is what our ultimate goal is for every setting where we implement it. And again, running monitor and evaluation underneath and throughout the whole process. I'm going to show you a little video. This is just a snippet of a video of the process that we undertook in Fiji, just to give you a sense of what it looks like. There's a little bit about the co-design and a little bit about the training itself.
What I have acquired from yesterday is just the right information to equip me personally, considering that I'm not a medical personnel and that I finished work, but to equip me in becoming a Vax champion.
There's teaching all the time. It's not just teaching from up here, it's teaching from within the different groups as well.
We work really hard to make sure that the country priorities are reflected in what we do, and it's definitely a case of using our skills and the skills of the team to help people recognise their own expertise and their own skills.
One-way information delivery about vaccination doesn't really change people's minds. We know that that's not a very effective way to support vaccine uptake and vaccine confidence. The key to encouraging vaccine uptake is really through community engagement and through communication with people that already have trusted relationships with different people in different communities. And that's really what the Vaccine Champions program capitalizes on by empowering lots of different people from lots of different backgrounds to effectively talk about vaccines and advocate for vaccines.
This will be amongst the first of a more proactive and planned management of intersectoral engagement within the community. What I'm hoping for is that you actually model this particular program so that when there is any important deployment in the community that we have to do, whether it's health related or any other thing related, we go together with an intersectoral community engagement component to each of that deployment. So please, I ask you to use your voices and the platforms that you represent to be champions for immunization in our wider community. And we at the Ministry of Health and Medical Services look forward to working with you all further in the future as you partner with us to be positive voices for immunizations in Fiji.
What I have
We don't need to watch it again. I just wanted to say that the vaccine champions have diverse backgrounds, and that's really important so that we're not just putting this role back to the health workforce. We had about half of them in Fiji had some health background, a lot of community health workers, very few in Tonga, and again about 2/3 in Vietnam. But the people that we brought together were from all different walks of life, and it really was based on that co-design session to identify who would be would have a meaningful influencer role in different communities. So with our monitoring and evaluation program, we were able to identify strong improvements within the champions themselves, in their knowledge, in their confidence to communicate, in their trust and confidence in vaccines. I'm showing you Fiji data, but it looks very similar in Tonga and in Vietnam as well. And within the actual community itself, we were able to see increases in intention to vaccinate and again in trust and confidence. Now, you will note that we don't have data at the moment that we can definitively attribute increases in vaccine uptake to this program. It's one of the great challenges of this kind of public health program, is designing it in such a way with an evaluation where you're able to measure that. But watch this space. I'll be talking about our plans in this space in just a minute. So just to switch at the end here to the work in the Philippines. So you'll hear more about this program from Professor Belisario and Margie in the panel, but this program is a little bit different. We started a step before. So rather than starting with the co-design session, we've worked with the University of Philippines to do formative research to understand the barriers to vaccination for COVID and routine childhood vaccines. The Philippines is one of the top countries with zero-dose children, so children who have received no childhood vaccines. So we really needed to understand what the drivers and barriers to vaccine uptake were, and also to understand what the implementation challenges and successes might be for rolling out a large-scale program like this. So we've just completed that work and are now sort of working towards the next steps of understanding what the program might look like. And in the Philippines and also in Indonesia, we're planning, our hope is to do a hybrid trial where we're able to actually assess the effectiveness at increasing vaccine uptake, but also cost effectiveness and implementation all in one large-scale cluster randomized controlled trial, which is really sort of the next step in pushing this field forward and in getting the right evidence to ensure that other countries are able to implement this kind of work. And these are some of the photos from our work in the Philippines, where all of the engagement with all of the different levels of government and all of the different key players has been a really, really important output of that work we've done so far. And I just want to acknowledge again, we also have a huge range of partners in every country, and of course, again, our great funding from the Australian government through ARIA. Thank you.
So thanks, Jess, for that great overview. And I think you'll agree that all three of these programs are really innovative and they're working across our region, as you've seen. So before we launch into our panel discussion, it's my pleasure to introduce Australia's Ambassador for Global Health, Dr. Lucas de Toca, who's going to give us just an overview of regional priorities and discuss the types of initiatives that funders and governments are looking to support. So, thank you.
Hi, thank you. I'll be very brief because I think it's far more interesting to move to the panel and hear from the audience as well. And the answer to the question as outlined is actually very simple. The programs that have been highlighted today that we are funding and supporting. But I think this ties in very well with the conversations we've been having throughout the day, from the opening sessions to the morning plenary and the challenges, as Jess acknowledged, and the some of the concurrent sessions this afternoon. We have been on a bit of a journey from what the Australian government funds in international health development. We were almost exclusively focused on communicable diseases, surveillance, traditional health security matters, with a very broad definition of health security, and I acknowledge that Professor Martinez will probably challenge a narrow definition of health security, but COVID confirmed what everyone probably in this room knew already, that you can't talk about health security without talking about strong health systems, that you cannot have bespoke field epi training or laboratory capacity if the workforce in your health system is going to collapse the moment two people get moved to pandemic-specific activities. The health workforce across our region, particularly in the Pacific with small populations, work in extremely challenging circumstances, show incredible leadership, but anyone who's worked in this region and anyone from this region will know that incredibly talented, very small groups of people actually run these health systems. Partners from all these organizations working in the region know that whether you're calling to talk to the top obstetrician or someone from the medical school or the person who runs the health department, you might find that it's the same person. So the capacity of people to engage with multiple partners, to work on different silos, to work on vertical interventions is quite limited. And that's why we have to be smarter on how we make it more achievable and we actually work to what the country's priorities are. The overall priorities in the region, we've talked about them all day, of course, climate change, recovering from the impacts of COVID and preparing for the next one, which won't be in a long time, unfortunately, will be closer than we all want it to be. Health workforce across the region and those multiple hats that we're talking about, integrating country priorities and traditional forms of knowledge into how we do things and not just what rich funders say the priorities are, and horizontalizing or diagonalizing those multiple vertical interventions. We can't move away from them. There's a lot of talk in the big global health initiatives about integration and horizontalization. The Lusaka agenda is working to get the Global Fund, Gavi, the GFF, which I never remember what the acronym is, the World Bank Fund that does maternal and child health stuff, and all the other global health initiatives more integrated, and that's great. And we have a similar journey here where we are funding all these things separately, but the partners are working very closely together. Our posts, our missions are working very closely with the national health departments and making sure that our approaches are integrated. But the more we can do in that sense, the best results we're going to get. The programs highlighted here are a very good example of how, even though on paper you're doing something vertical, you're actually investing in long-term partnerships, long-term relationships, capacity building, and doing things that are community-led and that put the people from the community at the centre. A lot of these programs have been going on for quite some time, and they have massively strong relationships and trust with the communities they work with. They leverage those strengths, and that's our recipe for success. We are still talking about communicable diseases formally, but you have seen community development in a much more clear way. And our final message is our role as a part of the DAC, our role as providers of official development assistance, is to respond to the priorities of the countries we work with. So, of course, Australian expertise is there and it's available, and we're incredibly innovative. Cervical cancer is another big example of where we are trying to make a big mark, and we also have a strong spiritual connection because of the development of the vaccine. Wolbachia, also one of our technologies. So we have a lot to offer. I said this morning we have a lot to learn, but ultimately we need to follow what our partners in the region are telling us the priorities are. Thank you.
Thanks so much, Dr. Toca, for those insightful comments. I'm delighted to now introduce our panel for today's discussion. So from the Australia PNG TB Partnership, we have Associate Professor Suman Majumdar and Dr. Nico Wotai. From the World Mosquito Program, we have Dr. Katie Anders and Chitra Indriani. And from the Vaccine Champions Program, we have Professors Margie Danchin and Vicente Belisario, or Jun. So thank you. Please come and take your seats on the stage. Okay, so hopefully that's working. So time for questions. I think there's a few themes that I'd like to explore here, but something that's come out again and again is community and collaboration. And so I might start, Katie and Chitra, with you. What have you learnt from working with communities and each other?
Okay, so it starts with me. Okay, so it's quite a lot of efforts actually, and really fun to work with the community. So in WMP, particularly in Indonesia, due to the nature of the implementation of the program, we barely need the community support. So community support is crucial in our implementation, and being supported by the community, it means that we need the successful engagement. And developing an early understanding is also a key of successful engagement. This is a shaking voice because of nervous or okay. And then building their understanding, it takes time. In our experience in Indonesia, it because of two things. The first thing is because the programs is contradict with our understanding for decades. Giving a mosquito in the population, and the understanding is to reduce the mosquito population. So it is not as simple as it is. And the second, this is a new thing, and in country, we have never been experienced it is this program at all. So these two things is challenging when we implement the program. And listening to the community also a key for success for the community engagement, and also listening to them is make our comms and community and engagement strategy is suited to what locally need. And also being transparent. This is a new, and we explain to them about the program is make a foundation for the trust. And for example, in Yogyakarta, we invite them into our insectary to see how the production is going on. There are no chips inside of the mosquito, and there is no big alien mosquito in the insectarium. So it is the similar. So there is nothing unless the truth for the community. So this is the basic of the foundation. And the other things is being a locally owner of the program, because this is important things also. They will have a strong engagement if they feel that they own the program, government and also the community. Not only in the community, but if the government is not locally on the program is will not be established smoothly. And the other things is also we face lately about misinformation and disinformation. Yeah. The disinformation hit us last year badly. Maybe the vaccine also experienced the similar things, but the massive social media is really hit us. It's like in a boxing ring, we are fighting each other, but then this is not a good strategy, and we are not experiencing with the disinformation. And with this disinformation, actually also we lost some of community support to our program. So I think that is I can share. Yep.
Thank you so
Maybe
much.
Katie wants to add.
No, you've covered it all.
Thank you.
So I might move then to Margie, you and Jun. Engaging stakeholders and advocates and building trust is an important part of your work. What insights can you add?
Thank you, Sarah. I think we've been hearing about trust since this morning. And trust is also about winning them over to your side. But it's not a one-way winning streak, but a win-win thing. that when they engage, they're also winners in their own right. They will get data that we actually generate, no, through research and development. And the data can be used for not just enhancement of policy and planning, including budgeting, but actually responding to head-on, targeting misinformation, targeting where the source of negative information is coming from. And of course, we've had experience where we help generate data. And by the way, it's not just generating the data by ourselves, but in collaboration with not just leaders in the health sector, local government, but also with communities. No, it's really top down across the board, and feedback, validation, no? Giving back information and maybe checking on whether we got it correctly or understood it correctly or not. That's the validation part. Being part of this continuing process of learning and being able to share such learnings for response and action. No? So such is the whole picture. No? Really it's engagement of not just community but also leaders in the health sector, including community and partners.
Thanks so much.
Yeah, I would just add that I think what Lucas said this morning as well, the value of social and behavioural science to really understand the drivers and what affects people's behaviour, understanding the root causes of misinformation, conspiracy theories. You need that information to understand who are the right people to engage with, who are your right messengers. In some settings it's more healthcare workers, in others it's more really diverse community leaders, religious leaders. It really depends what the key issue is. In Indonesia, in certain provinces, there are huge issues with halal, haram and religious concerns. In the Philippines, there's also some gender issues around, the very strong role of fathers in the decision-making. So really important to engage with men and fathers as well as mothers. So I think the key really with community engagement is to understand the core issues and those drivers and then match it with the messengers that you really need to engage with. And as Jess said, it's not just about calling someone a champion or an advocate, it's helping to equip them with the skills they need. And the first part is knowledge, depending on, doesn't matter which program, for us it's vaccines and vaccine preventable diseases, and those vaccine communication skills or communication skills in terms of how to have an effective conversation. Because as we all know, trying to convince someone who doesn't want to have a vaccine, I'm sure you all have family members or you've had these conversations that are very difficult, it's not easy. So helping people have those skills to have effective conversations, to not go into combat, is really important with the education and just matching the message with the messenger, I think.
Thanks so much. Suman and Nico, I'll go across to you. What has been your experience with engaging with communities, local leaders and governments?
Thank you very much. I think in terms of government response to the issue that we have in, especially in Port Moresby and in Daru, with regard to the management of TB in the country, it's been a problem. I think one of the reasons why the emergence of MDR, multiple drug resistant TB in the country, as well as we have cases of extensively TB drug resistant, is because of the failure to manage TB cases properly. When I was in my previous role as the manager for public health programs in Port Moresby, we had very poor outcomes with regard to treatment success rate with TB. Some of our treatment success rate in those years, I'm going back to 2014, 2015, were 50 to 60%. We were successfully treating our patients. as well as our defaulter rate was very poor. Almost a quarter of our patients were defaulting on their medication. So you can see that if you're not managing your patients properly, you will have an issue with drug-resistant TB. Prof. Suman has mentioned the issue with Daru. I remember going back to 2014, there was a big uproar in terms of 10 of our hospital workers infected with MDR. That was the reason why we set up, Prof. Suman mentioned about Dr. Kulala, the setting up of the emergency response team, looking at the TB issue in Port Moresby as well as in Daru. I think the setting up of this response task force was a response to MDR. And also, when I took up this appointment as looking after the health services in Western Province, Western Province is not an easy province to manage health services because it's quite isolated. You've seen those pictures, and in terms of capacity to manage these public health programs, it's very difficult. So one of the things that we have been looking at is to look at government policies. The establishment of the Provincial Health Authority in Papua New Guinea was one of the government policies that was implemented, and Western Province was one of the last to set up this Provincial Health Authority. That was in 2019. And since the PHA was established, we have been able to carefully look at our workforce, some of the reforms that's needed, looking at communication, etc. So in terms of the TP program, especially with the Western Provincial Health Authority, we've been able to work very closely with Burnett Institute as well as World Vision to make sure that we improve our treatment outcome with regard to TB program.
Suman, did you want to add anything?
Yeah, thank you, Dr. Ukta, and thanks for the promotion too. I think with the community aspect of this, I'd mentioned a few key points, but and these things are now moving beyond lessons. We know what to do in public health programming, having the community at the centre. But for TB, there has been a paradigm shift in the model of care over the last 15, 20 years or so, led by WHO, going from a very paternalistic delivery model where you observe treatment to a explicitly patient-centred model. And that was one of the pioneering steps that resulted in successful treatment outcomes, taking them from 50% up to over 90% in this emergency response in Western Province. Food support, peer counselling by people who are affected by TB, referral to family violence services, etc. Now, to the Ambassador's point, integration is key, but ultimately it's dependent on resourcing and what's available within that system. So if there was unlimited resourcing, you could do it all in some of these settings, but you have to prioritise based on provincial needs and community needs. And I think that was one of the key bits of work done early on, was sitting down, looking at community needs and how to deliver a model of care that is outside a health facility, because that was the sort of default model. And the formation of these PHAs and PNG was really catalytic in terms of, very similar to what Victoria's just done, in terms of decentralising care into a local public health unit, linking hospital through to community. Again, can't understate how important that is from a governance perspective. And finally, I'll just add I mentioned the community advisory group and the input from there. It is co-design in another term, but embedding that in public health programming across the board is I think, a way forward, particularly around key populations and groups. Adolescents are a huge part of the population and a really important group that are affected by TB. This is not a high HIV/TB setting like many other countries. And finally, with the community engagement as well, most people who've worked in PNG are aware that it's a diverse country and there's various different languages, so hence local responses are really needed to understand language, custom, and how to literally translate, but also adapt messaging to that specific circumstance. Thanks.
Thanks, Suman. We've seen how these programs have evolved from sort of small-scale projects through to much larger programs, and I think we've talked about scaling up and integrating into existing systems as being one of the challenges. So, Katie and Chitra, I'm wondering what challenges have you faced in that?
Yeah, thanks. Perhaps I'll start with some comments that are sort of cross-cutting across different project sites we've worked with, and Chitra can add any Indonesian perspective. I guess one of the challenges that we had in some of our earlier sites and that I think we've learned from and changed the way we do things is to sort of plan for that next step towards scale up and integration from the start, rather than sort of getting funding for a discrete project to do a proof of concept first in country demonstration project to show that it works, and then starting to think about what next. It's, right from the start and across all aspects, not just the local partner who's going to implement that project and that health authority there, but who do you need to engage with at a local level, province level, country level, so that they're aware of the intervention, what's being done, they understand it, they have time to, ask questions and learn from that first site, and that you're also then thinking about, even if you do it through hiring a project team, you're thinking about that knowledge transfer, capacity building, that you're then putting something in place that can build on rather than exiting and then trying to come back in. And I think, that's really key in terms of, I think it was just talked about, champions for vaccine. We also try and think about champions in terms of we're going to have most success in understanding what's needed in a given country in terms of the regulatory pathway, what's needed to unlock national government funds to be spent on a novel intervention, which usually requires it to be in policy rather than, where we start out just being regulated more like a research project, etc. Building the ability of the local partners to be able to speak to that from early on and understand it and be the ones to speak to the outcomes and impact, rather than early on some of the earlier projects, looking to WMP, what were the outcomes? We report the outcomes and share it with them, it really being coming from within. So I think that was a challenge. We haven't nailed it, but, learning how to do that better.
Just to add, in Indonesian context, when we are now we are adopting the Wolbachia method comes into the dengue control programs, and it takes years starting from the early research, and now we are in the mode of integrating with the dengue control program, and it is not easy because the national guidelines said that the dengue control approach is by reducing mosquito population. So it is not stated in the guideline that we can add the mosquito population. So they were reluctant, and then the second reluctant is because of fear of being what have they been worked and established for decades for their program, breeding site control programs, mostly for vector control. Will be replaced by the new innovation. So, but then we can deal with this with a strong advocacy. So there is a need for advocacy from research to control program. And also in the current moment in Indonesia, because we have more than 80% of endemic districts in Indonesia and currently hit by the dengue recently, and they are asking for Wolbachia. But asking Wolbachia is not as easy. I take the eggs and I bring to my home and release it. It is not about that, because many things. And Currently, we have a piloting in 5 cities in Indonesia beyond of Yogyakarta city, because successfully in Yogyakarta, it doesn't mean will be successful in another area, because Indonesia is very huge. We have eastern part and western part, and now we are piloting as a way forward for us to improving the technical guideline to ensure the quality of the implementation, particularly strengthening the community engagement and how we operate with the releasing mosquitoes. Yep.
Thank you. Jun and Margie, what insights do you have to add on scale up and integration of your program?
Given so much evidence, data, and the 3 initiatives actually are rich on monitoring and evaluation evidence, there's a need to really focus on a strong advocacy communications campaign that targets 4 Ps. When I look at public health, a spectrum of having to talk to policymakers at the top, they're the funders, policymakers, legislators perhaps. The second P is health service providers. They're the frontline health service workers. The third P is the public or the people. And the last would be partners who help you in your cause, not to actually win some more. 4 Ps: policymakers, providers, the people or the public, and the partners. And being able to speak the language that each level actually speaks. It cannot be from the point of view, just using the language of the academic, that might not be understood by 2 or 3 of those levels. Advocacy communications, therefore, of any initiative, public health initiative, great public health initiative, is not a nice to have but a requirement that must be funded. And it's not a 1 or 2 shot deal. It's a process of communicating, engaging in continuing conversation, making them ask questions to the point that they actually express some need that maybe service providers, technical support could provide. There's immense need for capacity development in public health. Capacity development that must happen as fast as it should. And we've seen that tremendous need during COVID-19, where the clock was ticking and we needed to act fast, double time, triple time, unlike pre-COVID time, where training was actually in a slow pace, never finished. For 17 regions of the Philippines, for instance, one training team goes around 17 regions. It's more than the 12 months of the year. And therefore, you'd like to think about training as orchestration of sorts, where you actually conduct a big orchestra, and probably if it's a chorale, multiple chorales, singing the same tune at the same time. I like the idea of the vaccine champions making use of master trainers, for instance. I like to think that the major academic institutions, higher education institutions, have major roles in particular regions, so that Ministry of Health or not even and even the National University, which is in the capital, can actually be replicating what is being done in different regions. So it's really orchestration of sorts. But the AC, advocacy and communications, plus T, capacity development or training, ACT is our acronym for that. I stop there.
Thanks, Jun. I would just add 2 things. I think for scalability and sustainability, the government or the Ministry of Health needs to co-design and own the program. It needs to be theirs at the end of the period of time that we've engaged. For example, in Tonga, they're taking it forward and the program's going to continue. Or in Vietnam, they've adapted with UNICEF for the champions to help with child nutrition. And that's because they really feel great ownership of the program. And the second thing I would say is we've got to get away from this vertical program of just focusing on immunisation and integrating across primary healthcare. So in the Philippines, we're actually planning to extend this program to include neglected tropical disease, so management of soil-transmitted helminths and schistosomiasis, which is a huge challenge in the Philippines, and it's a primary public health program for children. So engaging, other programs across primary healthcare and not just focusing on whatever your program is, immunisation, I think is really, really important, and talking about One Health and so on. So I think they're our greatest learnings so far in the work that we've done.
And Suman and Nico, you've already talked to pivoting with your program in the setting of COVID. Can you talk to how you've been integrating your work into the broader healthcare system?
Yeah, thank you. I think our response in Western Province in terms of the COVID response was one of the best in the country. The country in terms of its COVID coverage have been poor. But with because of working closely with our partners, we have been able to, and with the support of DFAT, we've been able to get a good outcome with our COVID response. I remember also, as you know, where Daru is close to the border. And there was a call for us to make sure that we increase our coverage along that border area, the treaty villages, and we've been able to get a good coverage in that area. This has led to the opening of the border. So I think it's...
Yeah, no, thank you. I can add a couple of more points to integration. I guess the first thing is, in a place like Western Province, there is no primary health care for the vast majority of the province. There's nowhere to integrate to. So the creation of community delivery systems has been a key part of the work. However, what I presented earlier, the work that's been done is not sustainable. There is no endpoint. Like most infectious diseases, the only exit strategy is reducing transmission and eliminating the threat. That will make the workload manageable for a health system, and strategies must be designed to do that. That's what the global goals for TB are. It's very challenging to do practically, so that's what the implementation research is about: is how to do that, how to screen communities repeatedly, how to prevent TB transmission, and how to integrate that into other pressing health issues such as maternal child health, immunisation in remote settings. Ultimately, the ingredients we've discussed multiple times. I think another key point I didn't mention was the joint planning that's done. It sounds very boring, and our country director in PNG has been key to this, Dr. Chani, where we've worked to integrate project plans into government plans at provincial and national levels. That allows that, but equally for integration, it's the donor partner communities that also need to facilitate that in their strategies. Without that from the top down, there's only so much service delivery and government partners can do. That, I think, is a unsolved piece of global health, and it's good to see, for example, Global Fund and Gavi coming together to integrate their strategies, which will translate through to the country level. Thanks.
I think all of the approaches that we've heard about here at face value are quite disparate. They're, targeting different diseases, using different approaches, but I think we've heard a lot of shared insights and shared challenges. And so I guess the question I'd like to put to anyone on the panel to answer is, how can we better learn from each other and adapt other approaches? John, you want to start?
I think the way to go forward would be becoming opportunistic in a good way. Because in public health, opportunistic infections we don't like. But opportunism in a good way would be targeting opportunities to continue to engage, to continue to discuss. I'm thinking about networks. I'm thinking about consortia. I'm thinking about platforms where you have stakeholders having common interests, generally common directed goals and targets. No? What brings us together? And the conversation is not just a conversation, but you carry it to a next higher level. No? Where, for instance, you generate data, you carry it to the next level where your generated data get utilized as part of policy or planning or budgeting. No? And we help each other along that way because some of us might be ahead of the others by way of they have scored in that regard in some way sometime before. I like a mix of young and not so young folks interacting with each other. No, in our team, we always want to target young ones joining us, no, because they are the ones we want to invest on them. They're the future. No, I'd like to invest on the young. They're the future. We're not going to be finishing these three major concerns we're talking about here in the next couple of years, and so we invest on the young. And I think you cannot go wrong with investing on the young because they will be the ones replacing us in the near or the not so near future.
Thank you. Katie, did you?
Sure. I guess I've got a couple of comments. One that's coming at this from the point of view of sort of within our program and cross-cutting across different countries, how can different programs learn from each other and sort of adapt the approach? And I guess one thing I'd say on that is to have that done. So I guess as a novel intervention, World Mosquito Program, we're not the only one delivering Wolbachia. We're the main one, but there are programs in Malaysia being done independently of us. There's a different use of Wolbachia in Singapore for suppression rather than replacement, but has a lot of the same elements of rearing mosquitoes and releasing them. So really creating opportunities for government to share those experiences, what works where, why do it this way here versus there, and from the community perspective as well, those shared experiences not coming via us, but really coming directly between the governments and the communities and other organisations who are on the ground doing this and sharing those experiences. And then I guess coming at this from sort of across our programs, what can we learn from each other and adapt is, something we think about is as we're scaling up, what are the, and I think this might be relevant to other programs, is sort of identifying what are the core elements of the intervention that are sort of non-negotiable, that are, or that, need to be done a certain way for it to succeed, that are really core, and what are really locally adaptable or could be, for want of a better word, outsourced or, done by other organisations in a different way that might be more efficient or might be more integrated with other programs, and really trying to think about not just it was done here this way, but pulling apart what the elements are of the intervention and which bits could be done in different ways by different partners in different places. So, yeah.
Suman, did you want to add a couple of comments? Or Nico? I did give the audience a promise that they would be involved in the conversation, so I might actually open questions up to the audience now, maybe just a couple of questions. There's some people with roving microphones, so if you have a question, please raise your hand and someone will bring you around a microphone. While I'm waiting to see if there's anyone in the audience who wants to ask anything. Oh yes, we've got one down the front here.
Yeah, coming back to the integration question, which I think is really important, how do you create incentives for integration? Because everybody's got their own barrow to push and their own needs to keep their resources to themselves, just to make sure their programs work. But what do you think the mechanisms or the vehicles should be to create better incentives for integration, whether it's across some of these topics or elsewhere?
Yeah, great question.
Maybe I'll have a start and then hand to Jun, but I think for what we're considering with immunisation and other primary healthcare programs, it's really identifying that it's the same people doing the work, and it makes complete sense. So it has to make sense to government to invest in capacity building across programs and to bring them together. And I think, when you look at the healthcare workers or the community advocates or the different levels, within the province of where health promotion or the healthcare workers are working, I think we just need to try and make it appealing to government to invest in bringing the programs together. And really, ultimately, we have to show them impact data. So we have to do the work to generate the evidence to show that it's worth investing. And I think Jess alluded to this at the end. It's time we started collecting more health economic data. We need to understand the costs of these programs and of implementing these programs successfully to be able to make a good argument for ongoing investment. It's not enough just to talk about an increase in coverage or, whatever our usual effectiveness outcomes are from a trial. We need implementation outcomes, and cost outcomes would be my sort of plug. But Jun, what do you think about integration?
I agree 100% with your answer. I look at it as savings in terms of time, effort, and resources, which could be tremendous if that would be factored in. In the decentralized health system of the Philippines, for instance, local health workers, the frontliners, are called by each program separately, in different venues. And you take them away from service delivery functions so many times. And this is going to be welcomed by local chief executives who actually supervise these local health workers. The costs for programs, both at national and local level, could be quantified, and I'm almost sure that it will show tremendous reductions. Meeting targets, reaching the unreached. Western Pacific Regional Office of WHO is meeting Thursday, Friday this week on reaching the unreached and technical advisory group for universal health care. And it's really integration to reach the unreached. Now, why will we go to the unreached area separately when we can actually capture the major high-ticket items there in public health at the same time, by the same frontline people? So integration is very attractive, and I'm hoping that we can win over those in the leadership to actually invest on that. To me, the investments of national and local governments, whether these are in cash, in kind, would be good indicators that we're winning them over, rather than programs, projects, footing the bill all the time. Over.
We've got one more question down the front here. Oh, one here.
Hello, can you hear me?
Yes.
Harvey Liwanag, Nasal Institute for Global Health, and Doc Jun was my boss a long time ago, so it's so nice to see you here.
He's everybody's boss. Everywhere we go in the Philippines, he was their boss.
Yeah, I'm glad to hear about collaboration and engagement, and I was wondering about, within Southeast Asia, I think we don't do so much South-South collaboration. So what I see is, for example, Australia working with Indonesia and Philippines, but in terms of Philippines institutions working with Indonesian institutions or Malaysian institutions, I don't see much of that, or am I wrong? And so my question is, how do we facilitate that South-South partnership within Southeast Asia and the region itself? Thank you.
Yeah. Chitra, did you have something?
So actually, we have in our university. Actually, we have collaboration between Philippines and Indonesia, and it is not related to. Unfortunately, it is not related to a certain disease, but it is for strengthening workforce for the epidemiology, for pandemic preparedness resilience. So I think it has been there, but I think we haven't. It is not covered in this discussion. Yep.
In the interest of time, I might just ask each of our panelists to give a very brief take-home message for the audience. So I might start with you, Nico.
Yeah, I think with us, working closely with partners is a major issue, because I know sometimes there are issues with government in terms of implementing programs. At this time, where we have major issues, I think the collaboration and working together with partners, and I know we've been working for quite some time now with Burnett's World Vision, another organization which is key in terms of improving some of our outcomes.
Thank you. Suman?
Yeah, no, thanks. I think one of the salient lessons is that equity needs to be at the core of everything in terms of strategies. Communities need to demand more. We need to enable them to do so around the issues around integration. And the questioner was absolutely right. There's not enough South-South collaboration that's resourced and supported, and that needs to be a future priority. Thank you.
Chitra?
Okay, so I'm copying the two questions that have been asking by the panelists in the in the morning. So what will be the next 5 or 10 years? So in the 10 years, maybe we, with the success implementation of Wolbachia, it will enable us to contribute in dealing the global warming impact on dengue burden as part of vector control management. And what need to be strengthened is particularly on the community engagement workforce that has not been familiarized, particularly for Indonesia, equip them with the disinformation skills, because currently disinformation is being organized, structured, and also massively. And then partnership for ensuring that all of high endemic area has the access for this technology. Thank you.
Thank you. Katie?
Yeah, thanks. I guess my takeaway would be that changing the status quo takes time. You know, with an innovative intervention, you can have all the evidence that it works and that it has impact. But yeah, changing the status quo it's incremental. It can't be imposed. And there's not a one-size-fits-all approach to how it's going to happen. It takes time to build that sort of understanding in communities and governments of how this will work locally, that you then need to have that ownership and sort of championship from within that's then going to enable you to have that sort of leap forward with how it's going to work at scale in that context. Yeah.
John?
I'd like to focus on the role of higher education institutions, academic centers. And in fact, I'd like to cite the ARIA partnership of the University of the Philippines. John Caldor reached out and said, and I was Dean of the School of Public Health at that time, we need an academic partner, things better there than us. We'd like to work with you. And I think that's the kind of attitude that opens the door for tremendous opportunities, where the role of academic centers is not just preparing the next generation of health professionals who will be facing these major public health problems we're facing now, possibly even more, possibly even the next pandemic, but a crucial role in data generation, generating evidence, but hopefully directed towards policy enhancement and development. Not just research that ends with the project, a report, and a publication stopping there, but really carrying it to policy level, policy and planning level. And lastly, being able to serve the third function of a university, and that's public service. They call it sometimes community extension. It's really sharing your expertise to the community. Different levels could be national, local, it could even be transnational if you have WHO or regional networks. Hence, a crucial role. And I'd like to say that HEI's academic centers invest a lot on preparing the next generation. And I'd like to bet on them. They're the future.
Okay, and Margie?
Lucky last. I think in addition to what's been said, I think we all agree that country priorities are at the heart of what we do. But I think every country has a very complex set of factors at play, and I guess I would make a plea to minimise duplication of effort and to understand what all the partners in a different country are doing. There are so many different groups from WHO, UNICEF, Save the Children, many different NGOs and other partners who are running fantastic programs. And, it's a crime really for us to invest resources in the same program at the same time. And I think we all need to learn to understand what everyone else is doing and collaborate and reach out and work together to really amplify all of our impact.
Well, thank you everyone for attending. That brings the session to a close. I hope you'll join me in thanking our wonderful speakers in the session today. I also hope you continue the conversation by coming up to our speakers throughout the meeting to talk to them about their programs and the work they're doing. So thank you.
Thank you, Sarah.